Hi everyone, this is how to read an X-ray, the basics. So this is just a very brief overview on some tips and tricks on how to read and then present an X-ray. So just some tips to start off with. Pick a pattern and stick with it. So when you're either looking at an X-ray, trying to describe an X-ray, there's a very specific way that you have to present it, but when you're trying to read an X-ray, picking a pattern, always looking at the same thing first and then going in a systematic way will make it a lot easier to not just read, but also present what your findings are in an X-ray. Practice verbalizing what you are seeing. It's very easy to look at an X-ray and see what is wrong. However, trying to verbalize what you're saying so that way someone who isn't looking at the X-ray is a whole nother thing. So as we move along through this, for what to include in your interpretation and how to present the X-ray, anytime you see an X-ray, practice verbalizing it out loud. It will help a lot, just in the basics of how to get across what you're seeing to another person. And then just some shout outs, the Sublux app, Ortho Bullets, they have a website and an app, and then Nail Fracture Conference, that is a website. Those are three great resources for the Sublux app is how to read and interpret an X-ray. The Ortho Bullets is great for just ortho in general, and then Nail Fracture Conference is a great way to practice interpreting and reading X-rays. So those three are great resources. Look into them if you have a chance. And then a lot of this presentation actually was taken from the Sublux app, the Nail Fracture Conference, Ortho Bullets, all just kind of meshed together, just so that way you guys can get a good understanding of the basics. Think about it and describe it. And again, I'm going to put this back up here. What views are you looking at? Are there any specialty views? Bones and joints, you're looking at the location within the bone. Laterality, is it the right, is it the left, is it the foot, is it the hand, is it the elbow? And then the location, is it the shaft, is it the base, is it the head, is it the neck? Mature, immature, adult, pediatric, fracture pattern, transverse, oblique, comminuted. Is it displaced? Is it angulated? Is there rotation? And is there shortening? Is it where the joints interact, or is it not where the joints interact? Is it open or closed? And is there any soft tissue involvement, foreign objects, or hardware that is already there? So if you can get anything out of this, it would be really, this slide is, I would say, the most important. Knowing how to talk about an X-ray and what to look at specifically. Thank you. With how you should speak about it. So this is a basic format on how to speak of an X-ray. So it would be, this is blank views of the laterality or whatever part of the body you're looking at in a skeletally mature immature patient, and it demonstrates whatever the fracture pattern is. You would insert that here through the whatever location on the bone it is, and then you'll start talking about the displacement, any angulation or shortening. And then you'll also want to add in, has the limb been placed in a splint or a cast or any traction or anything like that? Those are all important things. So an example of this being used would be, let's say you're looking at a lower leg X-ray, and it would be, this is an apian lateral view of the left lower leg in a skeletally mature patient, demonstrating a transverse fracture through the diaphysis. The fracture is medially displaced with significant angulation and shortening. There's a long leg splint placed on the limb. So you see how the template can just be used over and over and over, but you're able to talk about the different X-rays that you're looking at. So if you go by this template and use this pattern, it will be a lot easier to not just speak about an X-ray, but make sure anyone who's trying to listen or you're trying to tell understands what you're saying in a way that they can visualize it. All right, so the views, we're just going to go through each of those 1 through 8 a little bit more in depth. So in ortho or with any fracture suspicious of a fracture joint, we want to get at least 2 views of the fracture, whether it be an AP, a lateral, an oblique, or any specialty views like a axillary or a mortise or scapular Y view. You always want to get at least 2 views to look at both planes. X-rays can be very deceiving if you only look at an AP, for example. You can't tell any anterior or posterior shifting of that bone. So you always want to get two views. When you're talking about the bone and joint, you want to talk about laterality and the common name for the joint or bone or whatever body part you're looking at. So you would say something like, this is two views of the right wrist or the right foot or the right femur or the left hip or the left elbow. Whatever it is, you want to name or how many views, you want to give the number of views, what is the side, right or left, and then what is the name of what you're looking at. Skeletal maturity, so a mature or an immature patient, again, pediatric versus an adult patient. So you want to look at things like growth plates. So obviously here on the left, you can see there's growth plates here versus on the right. The growth plates are closed. So the left would be an immature patient over there, and on the right, it would be a mature patient. So that's what they're looking at when they're talking about skeletal maturity. That's important because the way you can treat different fractures depends on, is it a child or is it an adult? Is there room for growth or are they done growing? Fracture pattern. There's a lot of different types of fractures. Obviously, just on the right here is an example of some of the most common. So like the transverse, where it's just straight across, the linear, where it's just along the bone, oblique, where it's at an angle and it's non-displaced, versus an oblique where it's displaced. A spiral fracture, where it actually starts like up here and it spirals down and then around. The green stick, where only one of the cortices is disrupted. This cortex right here is not disturbed. And then comminuted, where there are multiple fragments. There's also, you can describe closed, open, is the bone going through the skin? Is there a disruption in the skin or not? Things like that you always want to report as well. Location on the bone, is it the epiphysis, the diaphysis, or the, is it proximal? Is it distal? So the base would be like the proximal portion, the neck, the shaft, the head, or is the distal portion. So those are commonly used in metatarsal and metacarpal fractures. The metaphyseal, diaphyseal, epiphyseal. When you're talking about the diaphysis, you can also say the proximal third, the middle third, or the lateral third. So if you split, the diaphysis into three, this would be proximal, this would be distal, this is the proximal third, this would be the middle third, and this would be the distal third. Specialty areas of the bone. The medial and lateral malleoli, any sesamoid bones, the femoral neck, intertroch fractures, subtroch fractures. Those are very common, the intertroch, femoral neck, and then the subtroch in like elderly patients who have a fall at home. So those are specialty areas of the bone. That'll be up here. And then that would be the femoral neck, which would be here. The intertroch fractures would be anywhere between the greater trochanter and the lesser trochanter. So it'd be anywhere in this area. And the subtrochanteric fractures would be anywhere here, or if it doesn't go quite to the greater trochanter. So there's a lot of different locations. As long as you can get your point across and the person you're talking to knows exactly where on that bone, that fracture occurred, that's all right. Displacement, angulation, rotation, and shortening. These are these four are, important and also very sometimes difficult to get across on the phone or if you're not seeing the x-ray. But first we're going to talk a little bit about like forces and traumatic forces that are applied onto the fracture. So if you have a complete fracture and then it displaces, you have different forces, the extrinsic forces and the intrinsic forces on that bone. So the extrinsic force is the traumatic force that's applied external to the body, and that what's actually is leading to the bony deformation, the displacement and or the fracture that occurred. So that would be you got hit by a car. That's a traumatic force that was applied not inside your body. Then you have the intrinsic forces, which are known as the deforming forces, and that's the muscular attachments to the bone that act on the fracture fragments, and that leads to the pattern of the displacement, the angulation, the rotation that's predictable. So, for example, a subtrochanteric fracture of the femur, like you see here. So the fracture pretty obviously is right here, but the proximal segment, that's this one here, it's flexed, externally rotated, and abducted because of the iliopsoas and the external rotators and the glutes that are acting on that proximal segment. So normally, when this is attached, these forces are always being applied onto the bone, but when it's attached, you don't have to worry about it because you have the other distal attachments down here. When you have this separation, these forces pull this bone and it externally rotates it, it abducts it, and then it flexes it. And that's what actually causes these deforming forces. So that's something to look out for. When you're looking at one of these fractures in like the ER, let's say, if you know it's a subtrochanteric fracture and you're looking at the leg, or you don't know it's a subtrochanteric fracture, but you're looking at it, there's an obvious deformation, like say a dent in the skin or like a little hill in the skin, and the joint is shortened, externally rotated. Obviously you can make some predictions or a differential of what is going on. So just different things to think about. Displacement. So describing displacement is a little weird. You want to describe the distal fragment in its comparison to the proximal segment of the fracture. So for example, in the upper extremity, you can have radial versus ulnar. So that would obviously be that the distal fragment is pointing radially or ulnarly, or if it's, instead of anterior posterior, volar versus dorsal, or in the lower extremity, medial versus lateral, anterior versus posterior. But it's really important that you describe the distal fragment as it relates to the proximal segment of the fracture. So you're actually describing this fragment, how it moves compared to this fragment, right? So the apex of the fracture may be facing volar, so the apex is here. However, if you're talking about displacement, it's dorsally displaced because the distal fragment of the fracture is actually displaced dorsally. So do you see how it can get very confusing based on how you're speaking? The apex is volar, however, there's dorsal displacement. It's very important that you describe that distal fragment to the proximal segment of the fracture. Angulation versus apex. So angulation describes the degree and the direction of, again, the distal fracture fragment. So it's the distal segment in relation to the proximal. Same, very, very similar as to displacement, just the angulation. And then apex. So if the fracture is angulated and displaced, that describes the direction of the fracture. So the apex, again, here is volar because the apex is pointing towards the palm in this case. So down here, you can see the angulation on an AP view. You have the midline here, and then the fracture, which goes across. This is the proximal segment. This would be the distal segment here. That would be the angulation of the fracture. And then you can also talk about displacement in terms of translation. So how much of the bone is actually, let's say, moved medial or lateral to the other bone. But again, you're describing it in terms of distal to proximal. So this is distal fragment is 80% translation from proximal segment. Shortening relates to the amount that one bone's decreased in the length proximal to distal. So you can use different words to describe it. You can actually give like a hard measurement in millimeters or centimeters, or you can say mild, moderate, or severe. If it's severely shortened, it's a significant amount. If it's mildly shortened, it's not a significant amount. So you can be displaced distally, angulated. It can be shortened here, so it could be shortened 1 centimeter, let's say, or mildly shortened, or it can be rotated around its axis as well. So those are the different ways for talking about displacement, angulation, rotation, and shortening. There's a lot of great YouTube videos that go way more in depth on how to speak about a fracture that way. However, this is just a broad overview working on understanding the different terms. Nail Fracture Conference also has a great course, and they show you hundreds of x-rays, and they give you the opportunity to describe them. So it's a great resource as well. So this is just a caveat for the upcoming x-ray reading clinic that we're holding. Common classification systems. So this is different than the AOOTA classification system. These are more used in like the clinics. However, if you look at the bone and joint and then the classification system it uses, you should look over, these are the most common ones, so you should look over for sure these if you get the chance. So femoral neck, Garden, the Pipkin, Freichmann, the Salter-Harris, that's a big one for pediatrics. Clavicle and proximal humerus both use the Neer. Distal humerus uses the Jupiter. The radial head uses the Mason. Tibial plateau uses the Schatzker. The ankle, there's Weber and there's Logie Hansen. The Weber is a much simpler classification system, speaking about the fracture in relation to the deltoid ligament. However, the Logie Hansen uses the actual movement that was used during the injury. It's a lot more complicated, a lot more that goes into that classification. But if you understand at least Weber, Logie Hansen gets a lot easier. But yeah, Logie Hansen's a much more complicated classification system to understand. The Calcaneus, the Sanders, and the open fractures, the Gustillo-Anderson classifications. So now we're going to go more into systematically reading an x-ray. So this goes by the first tip of pick a system, pick a certain way of doing it and stick with it. So we're going to go over some of the upper extremity first, just how I learned how to do it. You don't have to do it this way. However, this is how I learned, so you can stop listening now if you'd like. But again, pick a system that works for you and stick with it. So these are 3 pretty common views. You have the AP, the axillary, and the scapular Y. So obviously this is the AP here, right? And then, this is the AP, this is the axillary, and this is the scapular Y, and it's called the scapular Y because the scapula makes a Y. So pretty easy to understand that. But so in general here, you can see this is the clavicle, this is the acromion here, this is the coracoid, this is the humerus, and this is the glenoid. This is the coracoclavicular distance, right? So that's just AP shoulder bony anatomy. So what I like to start off with first is I like to look that the inferior acromion and the clavicle are well aligned. So you want to make sure that this here and this here make a nice arch that lines up well. Then I like to look at the corticoclavicular distance. So it should be about 1.3 centimeters. You don't want it to be um, larger than the 1.3 centimeters. If that's split, then obviously the corticoclavicular ligaments are damaged, and that's something that you have to look at further. So then you want to make sure that the head of the humerus is not directly inferior to the coracoid. So that would be, the head of the humerus being here, obviously. You want to make sure that the head is not directly inferior. So you want to make sure that the head isn't over here. And then you also want to ensure that the glenoid cavity, which is here, parallels the humeral head. See how they make a nice parallel line? That's what I like to look at on an AP view. Just, 1, 2, 3, 4, make sure everything is nice and, lined up as it should be. And then I'll go through, and I like to start superior and work my way down. And I'll just check to make sure that all of the bones that are in view don't have any fractures on them. So that would include the body of the scapula here. So, I like to start with the clavicle, then work my way down here to the acromion, look at the coracoid, look at the glenoid. Then I like to look at the humerus all the way down, and any bone that's in view here. And then you can also look at the body of the scapula as it goes back here. Just look to see if there's any fractures. And I like to do the same, 1, 2, 3, 4, 5. And that's just how I learned how to do it. So then, as we move along, I'm not going to spend too much time on this, but as far as with not necessarily this view, but if you have an apical oblique view, you want to make sure that the center of the humeral head is aligned with the center of the glenoid. Again, making sure that, the centers line up. Anything different would suggest, a tear in a ligament, in a muscle, dislocation. And then you also always want to check all the bones for any signs of fracture, especially the humerus and the glenoid. So then here on the scapular Y view, you want to make sure that the head of the humerus completely covers the center of the Y. So what that means, if you have the humerus here, it's the head of the humerus, and then you have the Y of the scapula. You want to make sure that the head of the humerus completely covers the center here. If it's displaced, it could be dislocated, so that's something you would want to be aware of. And then again, examine all the bones for any signs of any fractures. I do the same, 1, 2, 3, 4. And I just look at all of them to see if there's any fractures or any dislocations that are noticeable. So that's pretty much it for the shoulder. Again, here really quick, you can look center. So the coracoid. So on this view here, the axillary, the coracoid, it's called the lighthouse of the shoulder. That is anterior. So you can always tell which way is anterior because you'll see the coracoid. Something to keep in mind. All right, so as we move on, looking at the elbow. So you have the AP view, the lateral, and the lateral pediatric view, because the pediatric view is a little bit different, so it's good to keep that in mind. So first, for on the AP view, you want to make sure that the head of the radius, you want to look for any cortical disruption. Any fractures here can be subtle, so you want to be really careful while you're looking at the head of the radius. And then again, examine all the other bones and other structures for any fractures. you just want to be very careful looking at that. Make sure that those cortical disruptions in the radial head, you look very closely for. Look for any displacement. Look at the gap between, it should be nice and symmetrical as you go across. So in pediatrics, I don't have an AP for the pediatrics, but you want to ensure that the ossified centers appear in the order of the CRITOL. So that's just the capitulum, the radial head, the internal epicondyle or the medial epicondyle, the trochlea, the olecranon, and then the lateral epicondyle. You want to make sure that they're all in order. You want to make sure that the medial epicondyle will overlap with the humeral metaphysis. Then you want to check all the bones for any signs of fractures. So then you also don't want to forget the nursemaid's elbow because it has no radiologic findings. However, it is a thing. And then on the lateral view, so these are lateral pediatric. This is lateral adult. So right here, pediatric, you can tell growth plates are not fused. There's still ossifying centers. And here is an adult. All the growth plates are fused and there are no ossifying centers. Everything's fused together. So worry about the adult x-ray for now. Everything here is said goes for the pediatric as well. You want to make sure that the long axis of the radius intersects the capitulum. So the long axis of the radius intersects the capitulum here. So the capitulum, the head of the radius, you want to make sure that it goes right through the middle. You want to look at the fat pads. So the anterior and posterior fat pads should not be displaced. It's very, very difficult to see it on this x-ray. However, right here is the anterior fat pad, and then right here is the posterior fat pad. So this is the normal anterior fat pad. Right here would be if it was displaced. Any displacement of the fat pad could be a sign of a fracture, especially in pediatrics, that you can't see necessarily on the x-ray if it's not there. So always look at the fat pads because you can get what's called the sail sign, which is the displaced anterior fat pad, and that would be where all of this is displaced and it looks like a sail. So then you want to examine the radial head for any sign of fracture. Again, these can be very, very, very subtle and difficult to find. So you really want to take a lot of extra time whenever you're looking at the elbow to look right in here to make sure you don't miss any fractures. Then I just go on and look at the rest of the bone, see if there's any fractures anywhere else along the bones. So then in pediatrics, you also want to ensure that at least 1/3 of the capitulum is anterior to the anterior humeral line. So here's the anterior humeral line in pediatrics. You want to make sure that at least 1/3 of the capitulum is anterior to that. All right, so another thing to keep out for, I'll keep a lookout for in pediatrics. All right, clear this. Moving on, we're going to be looking at the wrist. This is a PA, a lateral, and then a scaphoid view. So you want to, again, know your bony anatomy. You want to know what you're looking at. So this right here, radius, ulna, styloid process. You have the scaphoid, the trapezium, the trapezoid kind of overlap in that view. The lunate, you have the capitate, you have the triquetrium, the pisiform is here, and then you have the hamate here. So you want to make sure that you can see all of the bones and on all of the different views, so they'll look a little bit different. So here, again, radius ulna, so this would be the AP view, sorry, the PA view. This would be the scaphoid view. And this would be the lateral view. So first off, I like to ensure that the styloid process is intact. It can be fractured, broken off in different fractures. You want to make sure that it's intact for both. You want to make sure that the articulating surface of the radius is intact, so that this is a nice and smooth, that there are no disruptions. You want to make sure that there's no fractures that go through this anywhere. Then I like to make sure that the ulna doesn't extend more distally than the articulating surface of the radius. So I want to make sure that these, again, line up. There's the break. You want to make sure that the ulna does not extend more distally. So ulna here, it's even. You did want to make sure that the ulna head isn't up here, because that would be more distal, and that would not be good. Signs of a fracture as well, or other things that could be going on further up the arm. Then you want to look at the scapholunate distance. You want to ensure that it's less than 2 millimeters. This can be widened in certain fractures. Again, you want to make sure that everything, a good rule of thumb is all of this, any spacing in between bones should be uniform. If it's not uniform, usually something else is going on. Then you want to look at the scaphoid specifically for any fractures. A higher risk for avascular necrosis is very difficult to spot the fractures, so you want to keep an eye on that and really look at that. And then for pediatrics, you also want to really inspect the radial cortex for any angulation or bulging. You can get that a lot in pediatrics, and you want to just be aware of it. The lateral view, you want to ensure the palmar tilt of the radius is between 2 and 20 degrees. So right here, you have the radius. You want to ensure the palmar tilt. Gonna do a great job with that angle here, but it's okay. But it is between 2 and 20 degrees. Right there. You want to ensure that the dorsal surface of the radius is smooth. Right. Here, nice and smooth. You want to make sure that the articular surface is smooth. Again, right in here, what articulates with the rest of the wrist. You want to make sure that the capitate is in normal position in the lunate. Capitate right here, lunate. You want to make sure that it sits nicely. You want to look for any bony fragments that are dorsal to the carpal bones. So you want to make sure that there aren't any here. Then again, you just want to check all the bones in general, see if you see any fractures or anything else that is going on. Scaphoid view, it's like it's oblique view. The specific scaphoid, it can be different depending on where you are. However, it's more of an oblique view rather than a straight PA. So you want to make sure there are no fractures or injuries to the scaphoid, because if there are, they can be very, very subtle and easily missed. So you also want to then inspect the radius for any fractures, including the styloid process. You never want to forget the styloid process up here. And you want to look very closely at the radial head and make sure that there are no fractures. All right, so moving on, I'm going to be looking at the hand. Going to be pretty straightforward as far as that goes. I like to, with the hand, start off by examining it and just looking 1, 2, 3, 1, 2, 3, 4, and just going down each finger, each segment, distal to proximal, to see if you see any fractures or dislocations. I like to start with that. Then you want to make sure that there's a visible gap at the fourth and fifth carpometacarpal joints. So that would be down here. I want to make sure that there's a visible gap between there. Then you also want to be very careful and look at the site that the abductor pollicis longus tendon inserts. So that would be on your first digit right here. You want to look for any irregularities or if there is an avulsion fracture. So because the abductor pollicis longus sits here and it has that force that can pull this way, if a fracture occurs here and it avulses, that entire fragment's going to shift out. So you want to just look at that very carefully. Then, so this is a PA view. This is the oblique view. For the oblique view, again, checking each 1, 2, 3, 1, 2, 3, 4, just going down each finger, distal to proximal, looking for any signs of fractures or dislocation, and you want to correlate that with the PA view. So you want to look at the PA, the oblique, see if what you're seeing on the PA lines up with the oblique or not. All right. This is a very, very brief overview. You can pause, replay, go back. I really recommend downloading the Sublux app. It makes reading x-rays much simpler, and they go over the same systemic approach. That's how I learned how to read an x-ray. So using that app really does help. So now we're going to go down to the lower extremity and really hit on the hip and pelvis, the knee, the ankle, and the foot. So the hip and pelvis, again, this is a AP and lateral view, or you're going to have AP and lateral views, but this is an AP of the pelvis, bilateral. This is an AP of the hip, maybe a little bit oblique here, but the different views, obviously you want to look at the bony anatomy. So as far as a hip x-ray, I start off with looking at the SI joints. So here, and then here. And you want to make sure that they're symmetric and they're not widened any more than 2 millimeters. If they're widened, that could mean instability in the pelvis. So the pelvis is a ring. If it's widened at one spot in the back, obviously there could be a second spot adjacent or across from there that could be fractured as well. So you want to look at that. Then I like to look at the pubic symphysis, where the two halves of the pelvis meet. It should be less than 5 millimeters wide. Again, if it's very, 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 very wide here, that means it's pulling this way and it's pulling this way. It shouldn't be doing that, so you want to look at that. Then you look at the main pelvic ring. Make sure that is intact. That was bad. Make sure that's intact. There's no fractures. Make sure that the SI joints and the pubic symphysis all line up. Then I like to look at the outer ring of the pelvis. So then I go all the way outside. And look again, any fractures or disruptions or dislocations that there may be. Then go to the obturators, same thing, looking for any fractures, dislocations, disruptions that could be around there. Make sure that they're smooth, that they're symmetric. Then you want to make sure that the arcuate lines are unbroken and they're symmetrical. So the arcuate lines are back here. Then after that, I like to go down. So I always start with, again, I like to start up top and go down. So you start with the SI joints, then you look at the pelvis as a whole, then you start to look at the hip. So you look at the acetabula for any asymmetry or any signs of fracture. So that would be in here. Are they symmetric on both sides? Or is there any fractures? Is there any degenerative changes? Is there any avascular necrosis? Is there anything you can see that's different between the two or on both? Then going down from there, look at the femoral head and neck. So I like to just, again, top to bottom, do the same thing every time. Make sure that it's centered in the acetabulum. So again, the head, make sure it's centered. Then especially in young adults or kids, you want to look at the apophyses for any symmetry and the signs of avulsion fractures. So anywhere where there are bony tendinous attachments, you want to look to see if there's any avulsion fractures or any other types of fractures that there may be, because those are weak points in young adults and children. So again, oblique view, more lateral, kind of different view, but you want to look the same thing. Start up above, find all of your foramen, all of the rings, look at the pelvis here as a whole, the SI joint. You don't have one to compare it to on this side, however, then I start going down to the acetabula, femoral head, the neck, greater trochanter, lesser trochanter, subtrochanteric, and then the shaft of the femur. So again, systematically. The knee. So with the knee, these are an AP and lateral of the knee, obviously. There's a lot of different views you can get. You can get, the sunrise. You can get weight bearing, non-weight bearing. AP and lateral you'll see most of the time. So that's what I'm going to go over. First, with the knee, I like to look at the tibial plateaus here. Make sure that they're smooth. There's no cortical disruptions at all. Then I like to go on to make sure that the tibia doesn't extend out more than 5 millimeters past the femur. So if you have the femur here, you want to make sure that the tibia doesn't extend out more than 5 millimeters past. Then you want to look to see if there's any increased density in any of the subchondral bone. So that would be down here. You want to see if there's any increased densities. You want to check the tibial spines, see if there's any signs of fracture. So that would be 2 little spines here and the 2 little spines here. You want to look at the contours of the patella. So again, patella would be here. Patella would be here. You want to look for any signs of fracture there. Then you want to look at the fibular head, the neck, carefully, and look for any signs of fracture here. And then again, check everything for any signs of fractures. So I like to start myself, top to bottom, look at the femur, look at the tibia, look at the fibula, and I look at the kneecap last or the patella last. That's just what I like to do. You can choose your own style of doing things, though. So in pediatrics, you want to check that the fibular and tibial cortices, you want to look for any torus or green stick fractures. So remember that green stick, one cortex is disrupted, the second cortex is not. And then you also want to check all the growth plates, look for any epiphyseal fractures. So that is, again, something you want to look for in peds because they have the growth plates. And then you also want to check for the femoral condyles for any fracture or lesions. So the femur, look at the condyles, see if there's any fracture there for pediatrics. And then on the lateral view, That would be here. So this is like a bent knee lateral view. You can get different, but um, so you want to look at the suprapatellar bursa and make sure it's less than 5 millimeters thick. Very difficult to see this suprapatellar bursa. However, here it's right here. Again, it's more of like a opaque strip between the two darker fat pads. Very difficult to see on some x-rays. Then you want to check the suprapatellar bursa for any fat fluid level. Make sure that the patella is greater than or less than or equal to 1.2 times its width from the tibial tuberosity. So what that means is you want to do that more on a straight leg. However, the distance between tibial tuberosity here, about here, and then here, here, and then here, 1.2, and the patella. So the patella is less than or equal to 1.2 times its width from the tibial tuberosity. Again, kind of difficult to see, but you can see here, this is where the patella is supposed to be. If the patella is up here, high riding. It's down here, it's low riding. That can cause issues. You want to check the patella for any signs of fractures. It's a better view to actually check the patella for fractures rather than just the rest of the knee. You want to make sure that the condylar surfaces of the femur are smooth. Make sure that they're nice and smooth. And then you want to examine the entire image for any small bone fragments, any fractures, or anything else that might be there. Small tip, a true lateral x-ray of the knee, the condyles both should line up. So this really isn't a true lateral because you can see here, this is one condyle, this is the second condyle. So they're a little bit unaligned. However, on a true lateral, they're perfectly aligned. Just again, something to keep in mind. The ankle, again, ankles are very complex as far as like classification system goes for fractures. You can see up here, there's a fracture here, here. However, you know, the Logge Hansen is a little bit more complex than the Weber. If you know the Weber, that's great. It's a great place to start. So AP lateral and the ankle specialty view would be the Mortise view. So down here, this would be the Mortise view. And what that does is here on the AP, you can see that there's a little bit of overlap between the tibia and fibula, tibia and fibula. Here on the Mortise, there isn't that overlap. And that's because you can stress the foot. And that you can do that with gravity or traction. However, you can check the fibula for defects, any oblique fracture lines, check the tibial cortex and the articular surface for any fractures or disruptions, check the talus for any fractures. So here, you have the talus here. Look to see if there's any fractures there. You want to make sure that you see the joint space between the talus and the navicular. So that's right here. You want to look at the calcaneum, see if there's any fracture lines or cortical disruptions there. Here is this bone. You want to check the entire cortex, look all the way around, see if there's anything there. And you want to look at Bowler's angle. I'm not going to worry too much about that. That's something else that you can look at though. And then on this view, you can also see here, it's the lateral view, you want to look at the base of the fifth metatarsal bone for any fractures because those can get avulsed. So you want to look, that would be back here. You want to look to make sure there's no fractures there. And then the AP or the Mortise view, so it would be up here. You want to look at the tibia and fibula, and there should be normally kind of like a small overlap here. The gap, you don't want it to be less than about 6 millimeters here. It should be about 6 millimeters there. You have the medial malleoli and the lateral malleoli. So you have the medial malleoli here, the lateral malleoli here. So this is the lateral, this is the medial. You want to look at the ankle joint and make sure that it's no more than 4 millimeters wide at any point, or that it is, and you also want to make sure that it is symmetric. So this joint right here, and to make sure it's symmetric and that it is no more than 4 millimeters wide at any point. Then you want to look at the talus, see if there's any signs of cortical disruption or any bony fragments there. And then in pediatrics, you want to make sure that the growth plates are normal, that there's no fractures extending along or through them. All right, gonna wrap it up here really quick with the foot. All right, so you have the AP, lateral, and an oblique view. So AP, oblique, and lateral. I'm not gonna spend too much time. It's very similar to the hand. You know, the feet are just the hands of the lower body. Not really, but you want to look at the second metatarsal, look at the Lisfranc joint and make sure it's well aligned. So that would be here. You want to make sure that this joint is well aligned. And then just like the hand, I like to go distal to proximal, 1, 2, 3, 1, 2, 3, 1, 2, 3, and just go distal to proximal along each of the toes, each of the digits. Make sure that there's no fractures or disruptions or dislocations along any point. The oblique view, same thing. You want to look at the third metatarsal and make sure that that's well aligned. You can see that a little bit better here. And then again, distal to proximal, looking at each of the portions, making sure there's no fractures or dislocations. You want to look at the midfoot joints and see that they're smooth and they're even. So all these joints here. You want to make sure that there's a good even spacing, they're smooth, there's nothing rubbing up against them. And then on the lateral view, that's your opportunity to check the talus and the calcaneum for any signs of fracture. So the talus up here and the calcaneum down here. You want to look at both of those, see any signs of fractures, disruptions. You want to look at the base of the fifth metatarsal for any fractures. It's down here. You want to look at the midfoot joint spaces again and make sure that they're nice, even, smooth. Everything lines up as it should. And that's pretty much it for the ankle, or for the foot. So all in all, it's very much just looking at, knowing and understanding what a normal anatomical x-ray looks like. And then when you're looking at one that is, has a pathological fracture or something else, you want to be able to know what is wrong with it and then be able to